Hey everyone, let's jump right into this focused explainer on the femur bone. This is designed specifically to boost your anatomy retention for your MBBS exams using active recall. We all know passively reading a textbook just doesn't cut it. You have to test yourself. So today we're going to actively quiz your knowledge on the longest, strongest bone in the human body. We'll present a concept, give you a moment to lock in your answer, and then we'll break down the high-yield explanation.
Here is our roadmap for today. We're covering 1. Orientation and side determination. 2. Proximal femur landmarks. 3. Features of the shaft. 4. Distal femur and condyles. 5. Key muscle attachments. And finally, 6. Clinical anatomy and fractures.
All right, Section 1, Orientation and Side Determination. Before you can understand the complexities of the bone, you really need to know how to orient it in anatomical position. So here's your first active recall question. Which 3 key anatomical features dictate the side determination of the femur? Take a sec to mentally recall the 3 main spatial rules. If you were handed a femur right now, what 3 exact things are you looking for to say definitively if it's a right or left femur? Think about the head, the shaft, and the condyles.
Got it? Okay, if you remember the medial direction of the head and the forward convexity of the shaft, you are absolutely spot on. To hold the femur correctly, that smooth, spherical head has to be directed medially, pointing right towards the acetabulum of the pelvis, as well as slightly upwards and forwards. And the long shaft? It's actually not perfectly straight. It features a very distinct forward convexity. Finally, those large, rounded, prominent condyles at the bottom must be situated posteriorly and inferiorly. Lock those 3 rules in, and you'll never get the side wrong.
Moving right along to Section 2, Proximal femur landmarks. This is a region of immense biomechanical stress and serious clinical significance.
Now, the femoral neck has highly specific relations and borders that are frequently tested in your examinations. We're looking at the anterior surface, the posterior surface, the superior border, and the inferior border. The reason these 4 distinct surfaces and borders matter so much is because they dictate exactly how the joint capsule attaches. And understanding where the capsule attaches on these specific surfaces tells you whether a fracture is intracapsular or extracapsular. That's a huge exam pearl because it completely changes the clinical outcome.
Next up, Section 3, Features of the shaft. The shaft acts as a massive pillar supporting our body weight, but it's also a heavily utilized canvas for muscles. Time to test yourself again. What is the name of the prominent longitudinal ridge running right down the posterior surface of the femoral shaft? Pause and think about this major posterior landmark. It serves as a massive anchoring point for muscles. If you run your finger down the back of the femur, you really can't miss this roughened ridge. What's it called?
It's the linea aspera. The crucial takeaway here is that the linea aspera isn't just some random bump. It is a fundamental biomechanical anchor for the whole lower limb. This prominent, roughened ridge features a medial and lateral lip. It acts as the central hub where major muscles pull against the bone, and it's also where the intermuscular septa attach, effectively dividing the thigh into its functional compartments.
All right, Section 4, Distal femur and condyles. This is where the femur prepares to articulate with the tibia to form the knee joint.
This next one is an incredibly common examination question regarding the distal features. Picture the medial epicondyle in your mind's eye. There's a very specific raised bony landmark sitting right there. Do you know its name?
Yep, it is the adductor tubercle. Located directly on the medial epicondyle, the adductor tubercle is a major, easily palpable landmark in lower limb anatomy. If you're a medical professional examining a knee, being able to palpate and identify that adductor tubercle gives you an immediate point of orientation for the medial side of the knee joint.
Let's slide right into Section 5, Key muscle attachments. Anatomy makes so much more sense when we connect the bony landmarks to the soft tissues that actually pull on them.
Let's test that active recall one more time. Which specific muscle structure is attached directly to the adductor tubercle? We know the bony landmark now, but what exact muscle structure utilizes this anchor point? The answer is the hamstring part of the adductor magnus. The major exam pearl I want you to lock in right now is this formula. Adductor tubercle equals adductor magnus insertion. Specifically, it's that hamstring portion of the muscle. This is a classic association that connects the bony structure directly to the muscular function of the medial thigh.
Now, truly understanding the femur requires knowing its developmental anatomy too, specifically this chronological timeline of its ossification centers. Bone isn't just static, it grows. Let's map out these milestones.
The primary ossification center appears in the shaft super early, right around the 8th week of fetal life. Then by the 1st year, a secondary ossification center appears for the head of the femur. By the 4th year, another secondary center appears for the greater trochanter. Knowing this timeline is absolutely key for interpreting pediatric x-rays and understanding how the bone matures.
Finally, we reach section 6, clinical anatomy and fractures. This is where your anatomical knowledge directly impacts patient care.
By comparing coxa vara and coxa valgus side by side, you can clearly see how pathological changes in the femur's angle impact overall limb biomechanics. The angle of inclination is that angle between the femoral neck and the shaft. In coxa vara, that angle is decreased, meaning the neck sits at a sharper, more horizontal angle relative to the shaft. Conversely, in coxa valga, the angle is increased, making the neck more vertical. These are vital clinical terms, guys, because a change in this angle fundamentally alters the mechanics of walking and places abnormal, damaging stress on the hip joint.
Okay, think back to the relations and that incredibly fragile blood supply of the femoral neck we discussed earlier. Here's your question. What severe clinical complication is a direct risk following a fracture of the neck of the femur? If a patient suffers a fracture straight through the neck, what is the most severe, life-altering complication that clinicians are immediately worried about?
It's avascular necrosis. Because the nutrient vessels are so easily torn during a neck fracture, avascular necrosis is an unavoidable clinical correlation you just have to know. The blood supply to the head of the femur actually travels up the neck in a retrograde fashion. So when the neck fractures, it acts like a pair of scissors, just snipping those delicate blood vessels. Without blood, the bone tissue in the femoral head literally begins to die. That is avascular necrosis, and it causes the complete collapse of the hip joint.
And today, we'll be hitting the osteology of the femur, crucial attachments, femoral blood supply, clinical anatomy and fractures, pathology and radiology, and we'll wrap it all up with a rapid-fire clinical challenge. So, let's jump straight into Section 1, Osteology of the Femur. Picture this. You're standing in the anatomy lab. If a very stern examiner handed you a bone right now and asked, left or right, what key landmarks are you immediately looking for? Take about 5 to 8 seconds right now to lock in your thought process.
Okay, time's up. So, to completely ace that spotter question, you've got to orient the head medially, upwards, and slightly forwards so it fits right into the acetabulum. You also need to ensure the natural convexity of the shaft is facing forwards. And crucially, this is the big one. That prominent, roughened ridge called the linea aspera, that has to face straight back. Get those 3 things right, and you will literally never misidentify the side.
Now, these specific bony landmarks, they're basically your ultimate roadmap. Up at the upper end, we've got the fovea capitis on the head, plus the greater and lesser trochanters. Along the shaft, the linea aspera is the absolute star, and it branches superiorly into the gluteal tuberosity and the pectineal line. Then, down at the lower end, you have those massive medial and lateral condyles, separated by the intercondylar fossa. And remember, these aren't just random bumps on a bone. They are critical anchor points for what we're talking about next.
Which brings us nicely to Section 2, crucial femoral attachments.
Think back to those long dissection days for a second. Which powerful muscles can you picture fanning out to attach to the trochanters? Take a few seconds to visualize it, because knowing exactly what muscle is pulling where, that's half the battle for any hip surgeon. All right, let's break it down. The greater trochanter serves as the major insertion site for your hip abductors. That's the gluteus medius and minimus. Meanwhile, that powerful flexor, the psoas major, inserts directly onto the lesser trochanter. Moving down the bone, the linea aspera acts as the origin point for your massive quadriceps muscles, specifically the vastus lateralis and medialis. Oh, and you definitely can't forget the incredibly strong iliofemoral ligament attaching right to the intertrochanteric line to prevent your hip from hyperextending.
Let's keep this momentum going into Section 3, femoral blood supply and ossification.
Okay, we really need to dive into this because it's so important clinically. The medial circumflex femoral artery is the absolute star of the show here. It supplies the vast majority of the femoral head through these delicate, highly vulnerable little retinacular branches that travel right up the femoral neck. We also get some contributions from the lateral circumflex and a tiny bit of supply from the artery of the ligamentum teres, also known as the foveal artery. Though, to be honest, that one is really only significant when you're a kid. Shifting gears over to development. This is a classic high-yield Viva question, and forensic anatomy absolutely loves this topic too. Take about 5 to 8 seconds and try to recall when exactly does the very first primary ossification center appear. It's pretty amazing, actually.
ossification starts incredibly early. The primary center appears in the shaft way back at the 8th intrauterine week. But here's a massive medical legal fact for you. The secondary center at the lower end appears right around the 9th intrauterine month. Forensics use that all the time to determine if a fetus was full term. After that, we see the head center appear at year 1, the greater trochanter at year 4, and the whole shebang finally concludes with complete fusion around age 18.
Let's head right into Section 4, Clinical Anatomy and Fractures.
Now, this right here is a massive exam point and a huge real-world orthopedic distinction. Intracapsular fractures, like a subcapital neck fracture, are totally notorious for tearing those delicate retinocular arteries we just talked about. Because they happen inside the joint capsule, the blood supply just gets ruined, leading to a really high risk of the bone not healing, what we call non-union. On the flip side, extracapsular fractures, like an intertrochanteric fracture, generally spare those vital vessels, which means a much, much better healing prognosis for the patient.
And that vascular disruption we just mentioned, it leads straight to this, avascular necrosis, or AVN. This is just a devastating complication. The bone tissue of the femoral head is literally starved of oxygen, and it actually dies. The cartilage collapses, the whole joint is destroyed, and the patient almost always ends up needing a total hip replacement.
Furthermore, if we look at shifts in the neck shaft angle, we see a really clear clinical distinction between coxa vara and coxa vulga. Normally, this angle sits around 125 to 130 degrees. If it decreases and drops below 120, that's coxa vara. That pulls the greater trochanter up, resulting in a shortened limb. But if that angle opens up past 140 degrees, that is coxa vulga, which results in a relatively lengthened limb.
Moving right along to Section 5, Pathology and Radiology.
The femur is, unfortunately, a really frequent target for both systemic and localized diseases. Whether you're looking at the classic presentation of an aggressive osteosarcoma down in the distal metaphysis of a teenager, or Ewing sarcoma showing up in the diaphysis, you've absolutely got to keep these on your differential diagnosis. We also frequently see osteomyelitis, which is a severe infection of the bone, as well as architectural diseases like Paget's disease and osteoporosis. And of course, those drastically increase the risk of the fractures we just covered.
When it comes to imaging, your X-rays are obviously your frontline tool. You must know how to trace Shenton's line. It's this continuous, smooth curve from the medial femoral neck right to the inferior border of the superior pubic ramus. If that line is broken, you need to highly suspect a fracture or dislocation. Now, while a CT scan is amazing for mapping out complex 3D fractures, remember that an MRI is your absolute gold standard for catching avascular necrosis early, way before it'll ever show up on a plain X-ray.
All right, we made it to Section 6, the Rapid Fire Clinical Challenge. Let's see what you've retained.
Here is your clinical vignette. Read it carefully. This is the exact type of scenario you're going to see on the wards and on your board exams. Take 5 to 8 seconds right now and formulate your spot diagnosis based on her age, the mechanism of injury, and precisely how that limb is positioned.
Did you guess a femoral neck fracture? Because if you did, you are absolutely correct. It's all about the anatomy. Because the bone is broken, that strong iliopsoas muscle that's attached to the lesser trochanter suddenly acts unopposed. It pulls the distal fragment upwards, which causes the shortening, and it rotates it outwards, causing that classic external rotation.
Okay, here's another classic spotter question for you. Let's see if you remember our osteology from earlier. What exact muscle attaches right to that small but incredibly vital adductor tubercle on the medial condyle? Take a brief moment to lock your answer in. Got it? It's the hamstring part of the adductor magnus muscle. Examiners absolutely love testing that specific detail. Finally, I'm going to leave you with this highly advanced, integrated mega challenge to ponder. If someone gets into a car crash and a dashboard injury forces their femur backward, straight out of the acetabulum, what strong anterior ligament is usually spared while all those posterior structures tear? And what massive nerve running right behind the hip joint is suddenly in immediate danger? Review your notes, check your textbooks to find out, and thank you so much for joining me for this